Safety and benefits of early urethral catheter removal after resectioning the recto-urethral fistula during posterior sagittal anorexoplasty. Samiul Hasan, Nazmul Islam, Refoyez Mahmud, Ashrarur Rahman. Introduction. Anorectal malformation, ARM, is a complex congenital condition. The type and severity of the anomaly can vary significantly between males and females. In boys, the most common type of ARM is rectourethral fistula, where the rectum ends in the urethra, either in the bulbar or prostatic urethra. This connection between the rectum and the urethra makes reconstruction challenging, as the two tracts share a common wall for some distance. Separating these two tracts is a critical process that must be done carefully to avoid injuring either. The Payne's posterior sagittal procedure became popular among pediatric surgeons worldwide after its introduction in 1982. This procedure offers excellent visualization of muscle structures, the rectum, and the urethra. Over the years, several changes have been made to simplify the process and enhance the results, such as laparoscopic fistula resection, muscle complex sparing SARP, and endoscopy-assisted fistula identification. In their report, Payne emphasized placing a urethral catheter to prevent urogenital injury and fistula recurrence. Payne's groundbreaking article recommended keeping the catheter in for 10 to 14 days after surgery. Most studies, regardless of whether they use a laparoscopic or perineal approach, recommend leaving the catheter in place for almost a week, and sometimes even longer after resecting a rectourethral fistula. This is due to concerns about the possibility of fistula recurrence or urinary retention during the immediate postoperative period. However, long-term use of a urethral catheter can lead to various drawbacks such as increased risk of infection, prolonged antibiotic therapy, longer hospital stays, and even urethral stricture in the long term. Catheter blockage and spontaneous dislodgement cause distress for patients, parents, and surgeons. In a report by Lepier et al., it was found that the catheter caused more discomfort than incision pain after radical retropubic prostatectomy. There is a growing trend towards early catheter removal after urethral procedures. In adults, research has shown that removing the catheter early after anastomotic posterior urethroplasty benefits patients. In children, stentless urethroplasty has shown better outcomes than stent urethroplasty. Snodgrass et al. Reported successful repair of urethrocutaneous fistula without requiring urinary diversion. This indicates that the stent does not prevent short-term or long-term complications. We hypothesized that removing the catheter earlier after the resection of the rectourethral fistula would reduce patient discomfort and a shorter hospital stay without compromising the treatment outcome. This study aims to present the outcome of early catheter removal after SARP surgery in boys with RUF. Methods. Before March 2021, we used to keep the urethral catheter in for 12 to 14 days after rectourethral fistula resection. After that, we changed our practice to remove it on the second postoperative day. We have compared the demographic and clinical data of these two patient groups. We have included all boys who underwent SARP from January 2017 to July 2023. Boys without rectourethral fistula, patients with rectovesical fistula, required an additional abdominal approach, abnormal sacrum, and whose stomas are yet to be closed were excluded. Patients who underwent reduced SARP, primary operation done elsewhere, were also excluded. The patients were divided into two groups. Group 1, patients operated on between January 2017 and February 2021. Group 2, patients who were operated between March 2021 to July 2023. Demographic and clinical variables were compared between the two groups. Outcome variables were postoperative urinary retention, difficulty in micturition, catheter blockage or dislodgement, fistula recurrence, hospital stay duration, and antibiotic therapy duration. Operative procedures. In Group 1, we strictly followed the Payne procedure. After identifying the fistula, we took multiple stay sutures proximal to it, continued the submucosal dissection up to the bladder neck, and then mobilized the full-thickness rectum. The urethral catheters were left in place for 12 to 14 days. If the catheter became blocked, it was removed. Further catheterization was not attempted in case of spontaneous dislodgement of the catheter. The patients were discharged after catheter removal. In Group 2, we performed a complete proximal separation of the rectum before dividing the fistula. This involved separating the rectum proximal to the fistula in the retrovesical space and pulling it upwards. The fistula was then divided without traction sutures. After surgery, the urethral catheter was removed on the second day, and patients were discharged on the third day. We published this technique earlier. Ethical clearance. Ethical approval for this study was obtained from the Institutional Ethic Review Board (IRB) of Bangladesh Shirshu Hospital and Institute. All procedures were carried out in accordance with the ethical rules and the principles of the Declaration of Helsinki. Statistical analysis. Data were analyzed using the Statistical Package for Social Science, SPSS version 26. Continuous data were presented as mean plus or minus SD, and the differences between the groups were analyzed using an independent sample t-test. The categorical data were presented as percentages and analyzed using the chi-square and Fisher's exact test. The p-value less than 0.05 was considered significant. Results. Data were analyzed on 54 patients who met the inclusion and exclusion criteria. Group 1 had 24 patients, while Group 2 had 30 patients. The mean age at operation was 10.6 plus or minus 9.1 months in Group 1 and 2.1 plus or minus 9.3 months in Group 2, and there was no significant difference between the two groups, p equals 0.57. In Group 1, 20 patients had a bulbar urethral fistula, while in Group 2, the number was 24, and the difference was not statistically significant, p equals 0.51. After the early removal of the urethral catheter, Group 2 had a significantly shorter postoperative hospital stay and duration of antibiotic therapy. In Group 1, 3 patients experienced a catheter block. In Group 2, 1 had spontaneous catheter dislodgement. Table 1 summarizes the results of patients in either group who had urinary retention, recurrence of fistula, or lower urinary complication. The minimum follow-up period was 6 months, ranging from 6 months to 4 years. The follow-up schedule included appointments 2 weeks after stoma reversal, followed by monthly checkups for 6 months, and then yearly checkups thereafter. It's worth noting that none of the patients in either group experienced urinary complications during the follow-up period. Discussion. Before performing SARP surgery in boys, a urethral catheter must be placed to prevent urethral injury. However, there is no agreement on how long to keep the catheter in place after the surgery. Surgeons tend to keep the catheter in the urethra longer to rest the repaired urethra and avoid urinary retention and fistula recurrence. However, there is no evidence that keeping the catheter in the urethra for a longer period prevents fistula recurrence. Moreover, it can be uncomfortable for patients. Pena et al. Stressed the significance of fully separating the rectum and urinary tract and sufficiently mobilizing the rectum to avoid recurring fistulas. A rectum that is inadequately mobilized and fixed under tension, or a rectum that is injured, repaired, and has its suture line placed over the repaired urethra can lead to fistula recurrence. A urethral catheter helps delineate the surgery but does not prevent fistula recurrence. Arunachalam and colleagues discussed their experience with urinary retention after SARP. They found that all of their patients had some form of urinary injury as a cause of retention. It has been reported that a significant number of patients who undergo SARP experience neurogenic bladder, which is thought to be due to extensive abdominal and retrovesical dissection or an abnormal sacrum. Hong and colleagues found that 10% of patients with neurogenic bladder after primary SARP at a neonatal age should wait until they weigh at least 25 pounds for definitive reconstruction. However, earlier anatomy reconstruction can help to attain the defecation reflex earlier. Our series had a higher mean age of reconstruction than most reported studies, which may be due to the socioeconomic background of our patients. No patient in our series had a urinary injury and postoperative retention. 4 patients in our Group 1 had catheter-related complications, and we had to remove the catheter early. These patients suffered no complications. Based on this observation and the evidence of successful stentless urethroplasty in children, we started removing the urethral catheter of Group 2 patients on the second postoperative day. This changed approach had no impact on the urinary outcome of these patients. However, it significantly reduced the postoperative hospital stay and the duration of antibiotic therapy. The study excluded patients with rectovesical fistula, as retrovesical dissection may cause temporary urinary retention. A longer urethral catheterization may benefit these patients. Conclusion: removing a urethral catheter on the second day after SARP surgery is safe. This improves patient comfort and reduces the duration of hospital stay and antibiotic therapy without causing urinary complications. During the surgery, complete separation of the rectum from the urinary tract and minimal retrovesical dissection should be prioritized. However, any urological injury during surgery may require a longer catheterization period.